Thank you. Good morning, everyone, and I'd like to thank the organisers for inviting me to speak. So today I'm going to talk about donor selection and review some of the data around how we select donors when the ideal donor is not available. Okay, so donor selection is mainly driven around HLA matching between a patient and a donor. So at the moment, the HLA identical matched sibling is the preferred donor. These donors are haplotype matched. If we don't have a sibling donor, then HLA A, B, C, DR, B1 and DQ-B1 match unrelated donors are still preferred option after the matched sibling. Remembering that these donors are still have some degree of HLA incompatibilities with their recipients, as the HLA haplotypes are not inherited from parents. And the survival is still around 50% after 5 years. If there is no 8 of 8 match, then a 9 of 10 match unrelated donor can be selected, or a core donor or a haploidentical donor. Other factors are also important, so donor age, and I will talk more about that later. CMV serostatus, sex, ABO group, blood group, parity, race, ethnicity, and even KIA. So in terms of trends around the world, it is pretty consistent across Europe and America and in our region. There has been a slight decrease in match-related transplants and cord units, an increase in match-unrelated transplants, haploidentical transplants, and in particular in the US, an increase in the use of mismatched unrelated donors. And for the reasons for these changes in trends will be the focus of this presentation. So a large part for the changes in donor source across the world is due to the introduction of post-transplant cyclophosphamide. So in 1999, Luznek and Fuchs at Johns Hopkins University pioneered the use of high-dose cyclophosphamide after haploidentical transplant to prevent graft-versus-host disease. So activated T cells are relatively more sensitive to the effects of cyclophosphamide compared to resting T cells. And following non-myeloablative conditioning, both the donor and the host T cells are exposed to alloantigens, resulting in activation and proliferation of T cells capable of graft-versus-host disease or host-versus-graft reactions. Expansion of the alloreactive clones occurs in the first 3 days after transplant, at which point cyclophosphamide is given to deplete the activated T cells. Haematopoietic stem cells and resting T cells are relatively resistant to cyclophosphamide, which preserves the T cells that recognise viral antigens and enhance the immune reconstitution. So as you can see here, between 2001 and 2008, initial clinical trials demonstrated that PT-Cy effectively prevents severe graft-versus-host disease while allowing engraftment. And since 2011, PT-Cy has been adopted beyond the haploidentical transplant and widely used in match-related, matched, unrelated and mismatched transplants. And today, PT-Cy has or is likely to become the standard GVH prophylaxis strategy across the different transplant settings. So you can see here in the red the increase in the use of PT-Cy, and this data is from the US. So who is the optimal donor when a 8 of 8 match unrelated donor is not available, or a matched sibling? And how has the introduction of PT-Cy as GVHD prophylaxis impacted on clinical outcomes and donor selection? So there has been a number of studies out of Europe and the US which have investigated the optimal donor, looking at both HLA and non-HLA factors. And again, this is the focus of this talk. So recently, with evidence that a younger donor is better, and as I said, I'll discuss that a little bit further later on, there have been a number of studies that compare the use of older matched-related sibling donors with younger 8 of 8 matched unrelated donors. So I've shown a few studies here in the slide. The studies presented here are in AML, ALL, and MDS patients. All patients were above 50 years old and were either given PT-Cy or traditional TACRO-based GVHD prophylaxis. These studies compared the clinical outcomes following transplantation with either a young unrelated donor who was less than 30 to 35 years versus matched sibling donors who were greater than 50 to 55 years old. So in the first study in the table, this was a small PT-Psi study that showed better overall survival due to less non-related mortality, relapse and GVHD that was achieved when patients were transplanted with a younger unrelated donor than with matched siblings. In the other 3 studies using predominantly TACRO-based GVHD, there was less relapse and better disease-free survival in transplants with younger matched unrelated donors, but an increase in GVHD and non-relapse mortality, leading to no net survival benefit over older matched siblings. The last study shown on the table used a different GVH prophylaxis and likely the reason for the non-significant findings. These studies highlight the use of a younger matched unrelated donor when the treatment for relapse is limited and the potential for improved outcomes when GVHD is kept at bay with the use of PT-Psi. All studies recognise the importance of not delaying the transplant in high-risk patients in order to find a young unrelated donor. So what factors should be considered when selecting the optimal haploidentical donor? So haploidentical patients and donors are matched for the 5 HLA-A, B, C, D, R, DQ alleles of the shared haplotype, but may be matched for any number of alleles on the non-shared haplotype by chance. However, the number of HLA mismatches on the non-shared haplotype has not been correlated with outcomes. Fuchs et al. In 2022 studied clinical outcomes based on the number and type of matched and mismatched loci. The cohort included 1,434 patients who had AML, ALL and MDS. These were given PT-Psi GVH prophylaxis, and transplant pairs were defined as A, B, C, DR or DQ mismatched in the GVH direction versus matched for each locus. They considered DPP1 TCE epitope matching, and the HLA-B mismatches were defined as B leader matched or mismatched. So just talking about HLA-B and the B leader in transplant. So we know that HLA-B is the most polymorphic protein encoding locus of the human genome, and there are clinically relevant variation that can include epitopes of the expressed HLA-B molecule as well as leader peptides. So exon 1 of HLA class 1 genes encode leader peptides that can be bound and presented by HLA-E, the ligand for CD94 and KG2 natural killer cells. HLA-A and C leader sequences are largely invariable, however, HLA-B are not. In HLA-B, there is a CT dimorphism at position -21 of exon 1 of HLA-B, which results in leader peptides with either methionine or threonine at the second residue of the processed leader peptide. And it has been shown that the M leaders promote higher HLA-E expression than the T leaders, favouring stronger T and NK recognition of HLA-E. So Petersdorf in 2020 identified 2 phylogenetically distinct lineages of HLA-B allotypes based on the M and the T leader sequence, and they defined 3 leader genotypes, either MM, MT, or TT. And the B leader in either patients or donors have been shown to be associated with increased grade 3 to 4 GVHD after transplant. So in single HLA-B mismatch transplantation, the mismatched HLA-B allotypes are considered as non-shared, and the matched HLA-B allotype is considered shared. In this example, the non-shared allotype is matched. Both the donor and recipient non-shared allotype has the methionine, while the shared allotype a threonine. This represents a MMT transplant. And the leader genotype of both haplotypes contributes to GVHD, and depending on the B matching and the genotype in the patient, each leader genotype has an associated level of risk. So we can translate this into the clinical practice easily. APHIA and the B, the Match Bioinformatics group, has developed a tool that can be used by the patient search coordinator to select B leader match donors. The patient and the donor HLA-B allotypes can be added to the tool to define the match status and recommends the best donor according to risk. So going back to the study by Fuchs et al., they found that HLA-B mismatching, when defined by leader match status, was associated with significantly lower overall survival and higher non-relapse mortality. DRB1 mismatching the GVH direction significantly lowered relapse risk compared to matching, and HLA-C mismatching significantly increased the risk of chronic GVHD, but had no effect on acute graft-versus-host disease. They reported that the optimal haploidentical donor was therefore matching at the B leader and mismatching at DRB1, which showed an additive effect, leading to improved disease-free survival and lower relapse rates. In terms of DR, due to the linkage disequilibrium, most transplant pairs were mismatched at both DRB1 and DQB1, with DRB1 mismatch, DQB1 match patients showing the best disease-free survival. Additionally, HLA-B leader matching combined with a non-permissive DPB1 mismatch was associated with superior overall survival. So putting together donor age and the HLA matching that I just discussed, a study by Meta et al. Combined age and haplotype matching for donor selection. So they use the use of a younger haplotype donor who was less than 35 years old was compared to older matched sibling donor transplants who were aged greater than 50 years old. So this study included 1,052 haploidentical transplants and 400 matched sibling donor transplants, both using PT-Cy as the GVHD prophylaxis. They showed that a younger donor age was identified as a significant predictor of improved overall survival across both donor types. Among the older recipients, younger haplotype donors who were B leader matched had superior overall survival compared to recipients of older matched sibling transplants. And younger haploidentical donors mismatched at DRB1 locus was associated with a significantly lower risk of relapse compared to older matched sibling donors. So now going to back to talk about donor age and non-HLA factors. So donor age in recent years has been shown to be an important non-HLA factor. The study by Shaw et al. Aimed to develop a composite score to prioritise unrelated donor selection based on multiple donor characteristics. However, the only factor consistently associated with improved patient survival was younger donor age. So they showed in patients who were older than 18 years old, who had AML, ALL, CML or MDS, and were given TACRO or cyclosporine-based GVHD prophylaxis, a linear effect where every additional year of donor age was associated with decrease in overall survival. Specifically, selecting a donor 10 years younger resulted in a 3% improvement in 2-year survival. And this study supported previous findings from Coleman in 2016 that showed donor age and donor recipient HLA match predicted survival after transplantation. More recently, Spellman et al. Used machine learning modelling to analyse just over 10,000 patient transplants and further validated results in an additional 1,800 cases. GVHD prophylaxis was a mixture of CNI and PT-Cy, and donors aged 18 and 30 years old yielded the best overall survival for patients receiving matched unrelated transplant. Donors 31 years and older were associated with lower overall survival. This study reinforces that younger donor age is most critical factor in MUDS. They also showed that male donors was associated with improved event-free survival regardless of recipient sex, but donor sex did not significantly impact overall survival. This data suggests that registries should recruit younger donors, less than 30 years old, regardless of donor sex. So how do we select the best single HLA class 1 mismatched donor. We know that HLA-A, B, C mismatching are present in more than 70% of single HLA mismatched mud transplants in studies from the US and Europe. We know that with every mismatch at HLA-A, B, C or DR, this reduces survival probability by about 10%. So how do we select between these donors? So in 10 out of 10 unrelated donor transplants, structural similarity of mismatched HLA-DP allotypes according to T-cell epitope groups were shown to define permissive mismatches associated with less mortality and GVHD compared with structurally dissimilar allotypes, defining non-permissive mismatches. These differences are reflective of a reduced divergence of peptide repertoire, that is, the immunopeptidome. Immunopeptidome divergence arises from distinct biochemical characteristics of peptides presented by polymorphic HLA allotypes, resulting in similar or differential peptide binding motifs. In this study by Ciavello et al., they hypothesized that the immune peptidome divergence, as predicted by differences in the peptide binding motifs of mismatched HLA class 1 alleles, might inform clinical outcomes in 9 out of 10 unrelated donor transplants. They studied 16,817 unrelated donor transplants between 2008 and 2018. Patients had AML, ALL or MDS, and this study excluded PT, Psi, GVHD prophylaxis. Approximately 14% of the 9 out of 10 approximately 14% were 9 out of 10 matched with either a HLA-A, B or C mismatch. PBM groups were assigned using second field HLA data. 21 PBM groups were determined for the 122 allotypes on the basis of hierarchical clustering of experimental determined peptide binding motifs, and the 21 groups are shown there in the table. So there is a tool to determine PBM matching, so you could use the tool in the clinic. So using this tool, the PBM groups can be assigned for each HLA-B allele, or for each class 1 allele. Both the shared and the mismatched HLA-A, B or C allele in the recipient and in the donor were assigned to any of the 21 PBM groups, indicated here in the table as PBM X, Y or Z. So if two mismatched alleles belong to the same PBM group, the immunopeptidomes presented by the mismatched allotypes have lower predicted divergence, and these are shown in examples 1 to 3 here. If two mismatched groups belong to different PBM groups, the immunopeptidomes presented by the mismatched allotype have higher predicted divergence, and that shown here in examples 4 to 6. In these cases, directionality is mediated by the PBM group of the shared allele. If none of the two mismatched alleles belong to the same PBM group as the shared allele, the mismatch is bidirectional, and that's shown here in example 4. If only one of the mismatched alleles in the donor or in the recipient belongs to the same PBM group as the shared allele, the mismatch is unidirectional, either GVH, as in example 5, or host versus graft direction in example 6. So the results of this study show that PBM mismatches in the graft versus host direction are associated with significantly worse overall survival compared to PBM matched or host versus graft mismatched transplants. PBM graft versus host mismatches had a high hazard ratio of 1.48 for survival, overall survival, indicating a high mortality risk. And there were stepwise increases in transplant-related mortality, acute graft versus host disease and chronic GVHD were observed from fully HLA matched to PBM GVH mismatched transplants, while relapse rates remained the same. Combining donor age and HLA peptide binding motif match status as described by Ciavello following CNI-based GVHD prophylaxis, Meta et al. Showed that older donors and the HLA match were both significant predictors of overall survival and non-relapse mortality. There was no difference in relapse, and the difference in overall survival was explained by non-relapse mortality. So in a multivariate analysis, the hazards of overall mortality increased in a stepwise fashion from HLA matched younger donor to HLA matched older donor, and PBM matched younger donor to PBM mismatched younger donor to PBM matched older donor, and finally PBM mismatched older donor. So selecting a younger donor seems to negate the detrimental effect of the HLA PBM mismatching, and similar patterns were observed for non-relapse related mortality. So we just heard that donor age is important, and so many of us have been prioritising DP matching in our clinical practice. So should we continue to prioritise DP matching over donor age? So in this study of 10,783 patients who underwent 10 out of 10 matched unrelated donor transplants with calcineurin inhibitor-based GVHD prophylaxis, the patients were characterised into 6 groups based on donor age and DP matching, as shown on the screen. And they showed that donor age was more important than DP matching for survival. So younger donors were associated with better overall survival in patients, regardless of DP match status. Older donors, in patients who were transplanted with older donors, greater than 35 years, they had worse overall survival across all DP matched categories. Direct comparison that showed that permissive mismatched younger donors had better overall survival than DP matched older donors, and non-permissive mismatched younger donors also had better overall survival than permissive mismatched older donors. Acute GVHD risk was high in all mismatched groups compared to DP matched younger donors, and chronic GVHD risk was highest in older donors, irrespective of DP match status. Relapse risk is lower in mismatched younger donors, and non-relapse mortality was higher in older donors. So I often get asked which donor is better, a mismatched related haplo, young mismatched related haplo, or a mismatched unrelated donor. So in this study, they compared these donor sources compared the haploidentical transplant using PT-Cy GVHD prophylaxis to a mismatched unrelated donor cohort receiving CNI prophylaxis. There were 1,434 patients in the haploidentical study or group. These were either B-leader matched or mismatched, and DRB1 matched or mismatched. And in the mismatched MUD group, there was 1,572 patients who received CNI and categorised according to the peptide binding motif, matched or mismatched, as I explained earlier. The haploidentical group had superior overall survival and lower non-relapse mortality compared to mismatched MUDs. And shown in the blue line, the patients receiving a haploidentical B-leader matched DRB1 mismatched donor had the best overall survival. The PBM mismatched, HLA mismatched MUD group had the worst overall survival and the highest non-relapse mortality, shown here by the black dotted line. In terms of relapse and progression-free survival, haploidentical donors with a B-leader mismatch had higher relapse rate compared to the PBM matched mismatch group, and haploidentical B-leader matched DRB1 mismatch donors had the best progression-free survival. The mismatched MUD group had significantly higher risk of acute and chronic GVHD compared to the haploidentical transplants. And haploidentical donor transplants were associated with lower GVHD risk, particularly with PT-Cy prophylaxis. So the study concluded that B-leader matched, DRB1 mismatched haploidentical donors had the best outcomes and should be prioritised when available. PBM mismatched HLA mismatched MUDs had the worst survival and highest mortality, making them the least favourable option. And younger donors, regardless of type, were associated with better outcomes, reinforcing the need to prioritise donor age in HSCT donor selection. They also conclude that further prospective studies are needed to validate these findings, particularly comparing mismatched MUD transplants and haploidentical donors under uniform PT-Psi GVHD prophylaxis. So I've tried to summarise here in a flow diagram how you might go about selecting donors. So this is essentially what we do in Perth. The highlighted factors are probably are the factors that have changed or will change in terms of how we select donors going forward, with prioritising age above DP. So in the search for a HLA identical sibling, going for a younger matched sibling, and if one's not available, moving to an unrelated donor search. In the mismatch setting, our centre uses CNI-based GVHD prophylaxis still, so selecting no DSA, prioritising age, and using the PBM matched algorithm. Haploidentical related donors with PT-Psi, again prioritising age, B leader matching, DRB1 mismatching, DP non-permissive. And then if we do have two fully HLA compatible donors available, then prioritising age. So in conclusion, donor age is critical. So selecting a younger donor improves overall survival and reduces relapse rate, and donor age should be prioritised over DP matching. Haploidentical transplant is a viable alternative, and selecting a B leader match DRB1 mismatched donor shows the best survival outcomes. And they outperform mismatched unrelated donors in terms of overall survival and lower GVHD risk when using post-transplant Psi, but more studies need to be completed in that space. PT-Psi has improved outcomes across all donor types by reducing GVHD-related complications, and again, the impact of PT-Psi on donor selection and survival continues to be studied. And donor selection should consider patient-specific factors, including disease status, urgency, to ensure transplant is not delayed while looking for the optimal donor. And generally for older patients, a younger haploidentical donor may be preferred over an older matched sibling donor. So thank you for your attention. Sorry, I've gone a little bit over time.
Okay, so we have time for one or two questions. I open to the floor. This is
This is very comprehensive overview, and I also learned a lot. But there are a few points I can ask question, but the most striking was the HLA-B leader peptide leader sequence. Most of the transplant center immune registries, they don't ask us to sequence for the leader peptide. So how you assume, is it a deduce leader peptide match or mismatch without knowing the sequence?
Yeah, so from the tool, you can put two field typing in, and it deduces the P leader sequence, so from the allele.
Yeah, we have certain HLA-B alleles that leader peptide is not sequenced.
Yeah.
So
you suggest to sequence the full gene? Is that
the system is not perfect.
Nothing's perfect.
Great talk, Dan. Thank you for summarising all of the new feelings. Mm-hmm. We've sort of muted this with the team in Adelaide, but there's still sort of a bit of a reticence to sort of move. How has it been received in Western Australia in terms of thinking about these options? Yeah, so I will go back in 2 weeks and present this talk, but we have been talking about, and the transplant units are moving to PT-Psi for all donor sources in the later part of the year. So
they have been asking between the older matched sibling donors versus the younger haplotype donor. So they are starting to have a appetite for that. They want the best for their patients. So, but it's a combination of ensuring that we're using the right transplant protocols and making the right donor selection based on those protocols. Yeah.
Great talk, Dianne, but it all seems very complicated to me now, choosing a donor related or unrelated. Would it not be easy, and this is a contentious question, would it not be easier just to go for 1 or 2 cords with a nice naive immune system?
Cords.
Cords, yes.
Cord transplants, yeah. Say this. We do look at cord units, but we tend to find our patients, especially in the adults, the cords are just don't have enough cells for the size of the patients that we're seeing. In children, they tend to lean in our transplant unit towards cords, if there was one available. But yeah, in the adults, it's getting difficult because the cords units stored are just not big enough for the patients that we see. That's what it comes down to, yeah. But maybe it is simple, maybe just choose a young donor.
I guess cords are expensive as well.
Yeah, I don't know. It's more about the size, yeah, the amount of cells.
Okay, thank you.
So if no questions, I would like to thank Dianne